Can you hear us?
Yes, sir. Your audio is.
Okay, we can start then. Yeah.
Good morning, sir.
Yes, please start.
Yes, sir. 1 second, sir. I'm seeing. Good morning, sir. Today's case capsule of mine is a 51-year-old male farmer by occupation and a resident of Alwar, Rajasthan, presenting with the chief complaints of difficulty in swallowing food for the last 6 months, associated with a weight loss of about 15 kgs for the same duration. The patient was apparently well 6 months back when he started having difficulty in swallowing food, more to solids than liquids. This difficulty started to increase gradually over a period of 15 to 20 days. It was also associated with mild retrosternal pain and chest discomfort, but without any association of regurgitation of undigested food, sour taste in mouth, or nocturnal cough. There was also no history of vomiting or early satiety. Associated with this was a history of weight loss of about 15 kgs in the last 6 months, which was not associated with loss of appetite. There was no history of black tarry stools or blood and vomiting, no history of change in voice. Also, there was no association with coughing on swallowing and no history of fever or night sweats. In the history of past illness, there is no significant medical illness or no past surgical history. In the treatment history, he was investigated in June for progressive difficulty in swallowing, after which he underwent upper GI endoscopy and biopsy. He underwent 7 cycles of chemotherapy. The last cycle was completed on the 10th of November of this year, after which he underwent a PET CT scan after completion of chemotherapy, and he now reports improvement in his dysphagia. In personal history, he has a past history of smoking BDs for the last 20 years. He smoked about 2 BD packets per day. However, he stopped smoking about 1 year back. There was no history of alcoholism. Bowel and bladder habits are normal, and there is also no history of any positive TB contact. The family history is not significant. So, summarizing the history, we have a 51-year-old gentleman, an ex-smoker, who presents with progressive dysphagia, more to solids than liquids for the past 6 months, associated with significant weight loss and no associated vomiting, hematemesis, melena, or loss of appetite. He underwent 7 cycles of chemotherapy, following which he reports improvement in his dysphagia.
Okay, go back. Yeah, so just explain why you asked the specific questions, because I'm sure the patient must not have told you all these things. You must have asked.
Sir, his dysphagia was, we asked that what was his grade of dysphagia, meaning how frequently was he having dysphagia, number one. Number two, was he having dysphagia more to solids, more to liquids, or in equal measure to both solids and liquids? This was necessary to quantify, to judge whether he's having a mechanical obstruction or a motility disorder, or he's having functional dysphagia. Also, we asked that was his dysphagia progressive?
Explain how you differentiate between these.
Sir, mechanical dysphagia that is caused by lesion in the lumen generally causes more dysphagia to solids than to liquids. Motility disorder have the reverse. They have more dysphagia to liquids than solids. And functional dysphagia will have more or less the same amount of dysphagia to both solids and liquids.
So what do you mean by what is the difference between motility disorder and functional dysphagia? What do you mean by functional dysphagia?
Psychosomatic disorders that cause the predominant symptom of dysphagia.
Because I think in general, we talk of mechanical obstruction and functional obstruction. Functional obstruction means motility disorder where there is no, I mean, you are trying to say psychosomatic is functional in that sense. But when we talk
Yes.
of esophagus, generally we say functional dysphagia means a motility disorder. So is the whether dysphagia is to solid or liquid the only difference, or is there any other difference? How do you differentiate between mechanical obstruction causing dysphagia and a motility disorder?
Mechanical dysphagia, predominantly that is caused by any lesion, will have a shorter duration of onset. Uh, Generally, um, it will be continuous. I mean, it's not generally it's progressive. However, motility disorders might cause intermittent dysphagia, have a much longer duration of history.
Yeah, so a long duration of dysphagia would exclude malignancy. You can't say mechanical, but it would exclude malignancy, isn't it?
Yes, sir.
Because a corrosive stricture, you can have a long history if the patient has not undergone treatment, but that also is mechanical obstruction. So
Yes,
long
sir.
history only excludes malignant cause of mechanical obstruction causing dysphagia. Then, as you rightly said, mechanical dysphagia starts with solids, especially those who are, and here the dietary history becomes important. Those who are not taking non-vegetarian diet, the first food to which they experience dysphagia will be meat rather than vegetarian food. So that is how you have to ask that what was the first food which you had problem with. On the other hand, with functional disorders, motility disorders, in some cases they may give the history that initially they have problem in swallowing liquids rather than solids. Why is that so?
Because it is theorized that the food bolus actually can make its way uh, beyond an esophagus that has a dysmotility disorder. However, liquids are more difficult in passing through uh, esophagus that has a abnormal peristalsis.
Yeah, so the explanation is that in functional or motility disorder, there is no mechanical obstruction. It is only that the normal peristalsis is not there. So esophagus is acting like an inert tube. It is like a tube. So solid, because of their sheer weight by gravity, they pass down, whereas liquids find it difficult. But it is not that every patient complains of that. And third,
Yes, sir.
very important point which you mentioned is that mechanical obstruction would usually be progressive. Whereas in motility disorder, it is intermittent. The patient has dysphagia for some time and then he or she feels that he can eat normally and then again there is dysphagia. So these are some points. And of course, age, a very young patient, you would not like to consider malignant dysphagia unless there are pressing symptoms or features to suggest that. These are some differences based on which you can differentiate between mechanical and functional. Okay.
Yes, sir.
Other things,
Um,
other
we,
symptoms.
we also asked that there was any uh, chest discomfort or pain over the retrosternal area or any back pain. He didn't complain of any back pain. He complained of a mild retrosternal chest pain, which he came out only on further questioning, but it was
No,
not
no.
reported by
Don't
him.
repeat what you have already said. Why did you ask about retrosternal pain?
Sir, we wanted to exclude GRD as a cause of dysphagia. So, and the further sequel of GRD as a cause of
So will
dysphagia.
the
So,
patient have retrosternal pain once the patient has started having dysphagia? What does dysphagia mean in GARD?
that he probably has a peptic stricture
So
or
the
he has
stricture
started
has
developing.
formed. Once the stricture has formed, will there be reflux?
No, sir.
There will not be reflux. So the symptoms of reflux will be present in the past. That will go into the past history that a patient who is presenting with dysphagia, does he or she give previous history to suggest symptoms of reflux? And now the patient has developed dysphagia. Back
Yes,
pain?
sir. Uh, Back pain typically occurs in advanced malignancies of the esophagus when the malignancy invades into the posterior mediastinum and the vertebral column, where he is supposed to have a deep boring pain over the back.
Yeah, so pain in these patients, you have to differentiate between pain, retrosternal pain, which as I discussed earlier, previously present, and now patient has dysphagia, which would suggest that earlier patient had gastroesophageal reflux disease, and now there is a peptic stricture which has formed. Second, it could be pain during swallowing, which is known as odynophagia, which is present in
Um,
any inflammatory.
yes, sir. And candidial
When the patient,
esophageal.
when the patient has reflux esophagitis, suppose the esophagitis is very severe, there is severe inflammation, inflammatory edema, that itself can cause little bit of mechanical obstruction. So that time, if the patient has difficulty in swallowing, it will be painful. Similarly, acute corrosive injury, when there is the phase of inflammation, that time if the patient tries to swallow, there will be dysphagia and there will be severe pain. So that is odynophagia. Other inflammatory disorders like fungal infection, candidiasis. Candidiasis will cause odynophagia, isn't it? So
Yes,
that is painful swallowing, pain during swallowing, which is odynophagia. Third is back pain. Back pain means that there is a malignancy which is directly infiltrating the posterior parietes, the muscles, the spine, the ribs, the intercostal muscles. That will cause sharply localized, continuous, dull pain, which is very severe, which is interfering with even sleep. And last could be a pain of bony metastasis, spinal metastasis, which could be anywhere. It could be in the dorsal spine also, which may be difficult to differentiate from the infiltration pain because both will be more or less same. So these are different types of pain which the patient can have. Classically, a patient with malignant esophageal lesion will have painless progressive dysphagia, like we have painless progressive jaundice in periampullary or cholangiocarcinoma. Same way, if you have painless progressive dysphagia in a, especially in a middle age or elderly gentleman, your first diagnosis, your clinical diagnosis has to be malignancy. Whether it is esophagus or GE junction, that you cannot differentiate on clinical grounds.
Yes, sir.
Last, vomiting and early satiety. Why did you ask?
So it was necessary to differentiate whether he had any vomiting or any regurgitation of undigested food. If he was having vomiting, we would have suspected a dysphagia that is more distal to the esophagus, that is causing the dysphagia and might be involving the esophagus. So there was no history of vomiting or even early satiety.
Which lesion will cause dysphagia and vomiting both? Because if you say that there is a lesion distal to the esophagus, which is causing dysphagia, obviously it is involving the GE junction.
Yes, sir.
You're trying to mean a proximal gastric tumor, which is involving the GE junction at type 3. So will that cause vomiting?
No, sir. Typically, it is first causing dysphagia.
So, see, negative history at this level, at MCH level, has to be a targeted negative history. It is not like an MBBS or even an MS student who is supposed to ask all negative questions just to complete the history. No, at your level, the negative history has to be targeted, because if there is a lesion in the stomach which is causing vomiting, then it will not cause dysphagia. So what can a lesion which is causing dysphagia either in the esophagus or at the GE junction, what will it result in? It will result in what you have mentioned in the second last sentence, regurgitation. What is the difference between regurgitation and vomiting?
Basically, regurgitation is the means reflux of undigested food without any frank nausea or effort, while vomiting is a forceful expulsion of partially digested contents.
So how would the patient tell you, what history the patient will give you by which you can say it is regurgitation or vomiting?
Vomiting will typically proceed with a nausea with forceful expulsion of bilious or non-bilious contents, while regurgitation is typically the effortless expulsion of partially digested food that he has taken probably yesterday night and appears in the morning. Also might be associated with sour taste in the mouth and bad breath.
तो ये तो तुम्हारा description है. What will patient say? A patient who's having regurgitation, what will he say?
Yes, because of still what we told.
Not sure, sir.
So he will say that whatever food he had taken, it comes back into the mouth. It doesn't come out, it comes into the mouth. Then he either spits it out or swallows it again. Whereas vomiting, whatever, because it is forceful, it is projectile, it comes out, isn't it? So
Yes, sir.
the patients don't tell you what you tell the examiner, patients tell you in their own language.
Yes, sir.
Why did you ask about nocturnal cough?
Associated with dysphagia, there is means we are trying to rule out the etiology by what is causing the dysphagia. If it was associated with GRD or an obstruction in the lower part of the esophagus, it might be causing repeated aspiration that can cause symptoms of nocturnal cough. So we wanted to rule out that.
And sour taste in the mouth.
Also to rule out GRDs.
So two symptoms which you have put here, regurgitation and nocturnal cough, are related to aspiration. Whereas the third one which you have put in between is related to GRD. That should have gone with the previous line where you were asking about retrosternal pain. So again, negative history has to be clubbed together in groups, and each group should have a meaning. So for example, you should say no history of high-grade fever with chills and rigors. When you are talking of jaundice, that indicates cholangitis. Similarly, when there is a patient with GI tract pathology, you say no history of hematemesis, melena, or hematochezia. So you are talking of GI bleed. So the negative symptoms have to be put in related groups, not randomly put here and there. Okay?
Yes, sir.
Next slide. Why did you ask about change in voice?
Sir, by this time we were approaching the diagnosis towards malignancy because he's a middle-aged male, progressive dysphagia, and history of weight loss. So we wanted to know that whether there were any signs and symptoms of associated infiltration to surrounding structures. Change in voice typically occurs in mid to upper esophagus lesions where it is involving the recurrent laryngeal nerves. So we
So
wanted
only
to
upper
rule out that.
esophagus lesions can cause change in voice?
When they involve the recurrent laryngeal nerves, if and when they involve the RN.
That you have already said. My question is only upper esophageal. What do you mean by
No,
upper
sir,
esophageal?
mid thoracic and upper thoracic also in the cervical esophagus.
So how do you divide, when you describe, how do you divide esophagus?
So the cervical esophagus is from upper esophageal sphincter to the sternal notch, corresponding to 15 to 20 centimeters from the incisors on endoscopic measurement. 20 to 25 centimeter, that is from the sternal notch to the lower border of the azygous vein, is the upper thoracic esophagus. 25 centimeter to 30 centimeter, that is the lower border of azygous vein to the lower border of the inferior pulmonary vein, is the mid-thoracic esophagus, while 30 to 40 centimeter from the upper incisors corresponds to the lower thoracic esophagus.
That's all? There is no other part of esophagus? You said cervical, you said upper, mid, and lower thoracic. That's all? Esophagus ends in the thorax?
GJ junctions.
There is an intra-abdominal part also.
Yes, sir.
So normally when you talk of esophagus, you say cervical, thoracic, which is divided, as you rightly said, into upper, mid, and lower. If you are describing on CT, then it could be supracarinal thoracic and infracarinal thoracic. And there is a small length of intra-abdominal esophagus, which is between the esophageal hiatus and the GE junction. GE junction lies in the abdomen. Between that, there is about 2, 3, 4 centimeter of intra-abdominal esophagus. So going back to the question, you said only upper esophageal tumor, and I hope you are saying cervical esophagus can cause change in voice?
They might, sir, if they're infiltrating into the islands.
So cervical and upper esophageal lesions can directly infiltrate the recurrent laryngeal nerve, because on the right side, the recurrent laryngeal nerve goes down also.
Yes.
But can a mid or lower thoracic esophagus lesion cause recurrent laryngeal nerve involvement
Unlikely,
or
sir,
change
but
in voice?
uh, uh, generally unlikely. But if the metastatic node compresses upon the
Yeah, so
RLN,
nodes can cause. So it is not that only upper cervical or upper thoracic lesions. That is, yes, common. But even lower thoracic esophageal lesions, by causing lymph nodes in the upper mediastinum or in the neck, can cause change in voice. Okay. Last, no history of fever or night sweats. What are you trying to hint?
um, whether there are overt symptoms of any disseminated malignancies.
Sorry?
Disseminated malignancy, we wanted to rule out.
Night
So
sweats in malignancy?
means uh, basically, sir, we were pretty sure that we were approaching a malignant diagnosis. So we wanted to confirm any additional history, whether there
So you
is
have fever in malignancy, especially esophageal malignancy?
not generally, sir. It's more common in lymphoma and or
So this
tuberculosis.
feature of fever and night sweats.
Fever and night sweats is characteristic history of what?
Which disease?
Lymphoma, sir,
Right?
and tuberculosis.
Which one comes first?
In India, sir, tuberculosis.
So what is the hesitation? So, but when you are trying to take a history of general or systemic symptoms of tuberculosis, it would have been better if you had said there is no history of low-grade fever with evening rise, there is no history of night sweats. That tells me that you know the systemic symptoms of tuberculosis and you have asked for it, because the other symptoms like anorexia, weakness, loss of appetite and weakness and fatigue, they can be there in malignancy also. They can be there in any blood loss also.
Yes, sir.
So again, when you mention any negative history, it has to be very specific and it has to be a targeted negative history. Okay, next. Next. Yeah. So what do you think of this?
This makes my diagnosis even further. I will able to clarify further that my diagnosis is approaching towards a malignancy, because he underwent biopsy, endoscopy and biopsy followed by chemotherapy, and he reports improvement in dysphagia. It also
Don't
tells me
repeat
that
what is written, what you have already said. I am asking you, what do you make out of this? So please don't repeat. This is a very common mistake which all of you do.
it tells me that probably the malignancy is responding to chemotherapy, sir.
So first you should say that it confirms the diagnosis of malignancy. Isn't it?
Yes, sir.
Then you say it has responded to chemotherapy. What else can you make out of this? Can you predict the histology?
Sir, chemotherapy regimen is more commonly used in adenocarcinoma, so the tumor might be a adenocarcinoma.
So in squamous cell carcinoma, chemotherapy is not used?
It is used, sir. We use it in our institution also, but the preferred means for both adenocarcinoma and squamous cell carcinoma, now preferred is chemoradiation, but chemotherapy we
You say
use.
again, you said for both chemoradiation is preferred.
Yes, sir. As per NCCN guidelines, in 22, both chemoradiation, as per the cross protocol, is uh, preferred for both adeno and squamous carcinoma.
So is that the only protocol?
No, sir. It's according to the cross regimen, but we can also use the FLOT4 regimen,
which is
4 cycles of chemotherapy consisting of 5-fluorouracil, leucovorin, oxaliplatin and docetaxel, followed by surgery after almost 1 month, and followed by post-operative 4 cycles of chemotherapy consisting of the same drugs.
Yeah, so since we were discussing chemotherapy versus chemoradiotherapy, the answer should be that there are different regimes. Some regimes include only chemotherapy, and some regimes include chemotherapy and radiotherapy.
Yes, sir.
And depending on what regime you are using, it is very difficult to predict based on use of chemotherapy alone. What is the histology? But if chemoradiotherapy was given, then it was more likely that it is squamous cell carcinoma.
Yes.
Anything which you would have done differently so far? So how do you, okay, yes.
I would,
how do you say, you made a statement that he has probably responded. How do you say that?
because compared to earlier, his earlier complaints, he is now able to take some amount of solid food that is much more in quantity that what he used to take previously.
So is it the quantity of food which decides
No,
whether?
sir, means feeling of dysphagia also has gone down significantly as he is reporting. Also, but there is no objective improvement in his scores, such that means he was also taking solid food previously. He can take solid food also now, but his feeling of choking and his hold up sensation has now gone down significantly.
So a better answer would be that I would like to know what all food he could take earlier and what all food he can take now, the type of food, whether normal solid food, and as I said, that meat or not meat, and then soft solids, liquids, the time which he takes to eat. So some patients with mechanical dysphagia, if they eat slowly, they eat little by little, they can eat equal amount of food, but it takes more time. Whether he needs to gulp it down with swallows of water in between. Every time he eats something, he has to take water, then he eats little more, then he takes water. So all these things collectively give you an assessment. So how do you assess response to chemotherapy?
We do a FDG PET CT.
That is the only way. The first step to assess response to chemotherapy is FDG PET.
Also an upper GI endoscopy to look for the amount of circumference that the growth has involved.
So correct answer would be that assessment to any neoadjuvant treatment is assessed in several ways. It starts with clinical, which we have already discussed, improvement in the symptoms. Second is endoscopic. Third is imaging, CT scan, even CT will tell you. Fourth is biological, which is PET scan. And not here, but in some tumors like pancreas, you could even assess biological, or a liver tumor, you could assess biological response by the level of tumor marker.
Yes,
so
sir.
that is how you should answer. Every answer should be given in a systematic way, not in a random way. You can't straight away go to a PET CT scan. So here, can you say whether the patient has responded based on PET CT scan?
Based on clinical and PET CT scan, we can say that he has responded.
May
Now,
I
can
ask
you
a
say
question,
that
sir?
when you don't report that a PET CT was done before the chemotherapy? He has told you that a PET CT was done after chemotherapy.
Yes, sir. He has actually underwent a PET CT prior to chemotherapy.
Yeah, but in your history, if you have said that he underwent a PET CT after completion, you should have told that he had a PET CT before also. Otherwise, you cannot say that he has responded. You have to have the baseline investigation and then the post-chemotherapy investigation. Okay?
Yes, sir.
Yes. Carry on.
May I interrupt, sir?
Yeah, Rajan, please.
Yeah. In a patient about to undergo chemoradiotherapy, high-grade dysphagia, how would you maintain his nutrition during the period of chemotherapy? Because he's going to be very nauseous, he's going to be very sick, and FLOT4 has significant side effect of post-operative nausea and vomiting. Same is true of lesser methods of chemotherapy. So what would you do? How will you maintain his nutrition?
Sir, as as far as this patient is concerned, he was able to tolerate liquids also.
Yeah, so what would I asked you a general question? How will you manage his nutrition? You tell me all options. You classify and tell me all options that you have in a patient with advanced carcinoma of the G junction or esophagus.
Initially, if the patient can take orally, sir, we will try for an enteric supplementation. If it's at all not possible, we would go for a FJ to supplement his nutrition. Even if it's not means he's not able to tolerate his FJ feed, we would have to consider TPN. And lastly, I would consider endoscopic stenting to uh, encourage oral feeding.
Yeah. So was any of this done?
No, sir.
So they have relied on enteral nutrition. He has
Yes, sir.
lost 15 kgs. What is the influence of frailty and prehabilitation in this case?
Sir, pardon, I could not understand your question.
Frailty. Do you know what is frailty?
Sir, the influence of muscle mass and the body fat stores that the patient has.
So
What happens to them?
Yeah, please, Rajan, carry on.
Yeah. What happens to a patient if you leave him nutritionally unsupported? Is at the end of chemotherapy, you'll have a patient who is unfit for surgery. As
Yes,
of
sir.
now, data is even when there is complete response on CT, you have to offer a resection to all patients you have given chemoradiotherapy. Because on microscopic pathology, only about 60 to 75% have responded pathologically.
Yes, sir.
Do you agree with that or you don't?
Sir, resection can be offered to the patients. That is correct, sir. But there is a protocol of giving definitive chemoradiotherapy and waiting means for salvage esophagectomy, especially in patients with squamous cell carcinoma. Also, definitive chemoradiation is the treatment of choice for cervical esophagus.
It was one of the options many years ago, but data now shows that in up to 30% of patients, there is a residual tumor on the esophagectomy specimen. So the current consensus is that you do a esophagectomy after 6 to 8 weeks of chemoradiotherapy.
But in any case, Pranay, here the patient has received only chemotherapy, isn't it? He hasn't received any radiation. So
yes, sir.
He doesn't fall in the definitive chemoradiotherapy protocol.
No, sir.
It is given as a neoadjuvant. What Dr. Desai was trying to impress upon you, that this patient you said that has lost 15 kg weight, which means that his nutritional supplementation, his prehabilitation preparedness for surgery has not been adequate. And the answer should have been that if the patient can still tolerate liquid diet, then I will supplement him with enteral liquid nutritional diet. If he cannot, then there are options, starting with placement of a nasogastric tube. If the passage is still there, then you have the option of esophageal stenting. The stent then comes out with the specimen. Of course, it involves cost. And third option, as you said, is FJ. I don't think there was a need to say that if the patient doesn't tolerate FJ feed. Why should the patient not tolerate FJ feed? There is no reason. So don't bring that in unnecessarily.
Yeah.
Okay, sir.
And would you prefer a gastrostomy or a jejunostomy?
I would prefer a jejunostomy, sir,
Why not a gastrostomy?
because I might have to use this. Our my choice of reconstruction is with the stomach conduit, so I will not compromise it with doing an FG.
Yeah. And in G junction tumors, these facts do not apply. What we have discussed is applicable only to squamous cell carcinoma of the esophagus. If it's a G junction tumor, you cannot utilize the stomach because a large portion of the stomach would be excised with the surgery of the G junction tumor.
Yes, sir.
So you won't have much stomach, especially in type 3.
Yes, sir.
Yeah, continue.
Carry on. Yes, carry on with the examination.
Yes, sir. On examination, he's conscious, oriented to time, place, and person, sitting comfortably in bed. His hydration status is adequate. Performance status ECOG 1 with a BMI of 23.3. Breath holding time of 25 seconds. Vitals are normal with no pallor, pedal edema, left subclavicular lymph node, icterus, cyanosis, or clubbing. No halitosis, tooth erosion, oral thrush, or atrophic glossitis. On inspection, his abdomen is flat, umbilicus is centrally placed, inverted, with no visible peristalsis or pulsation, no epigastric mass of illness, no other significant findings on inspection, and external genitalia and hernial orifices are normal. There is no flank fullness also. On palpation, all inspection findings are confirmed. Abdomen is soft, non-tender, with no local raise of temperature in the abdomen. No palpable lump or nodules, no palpable thrill, or no hepatosplenomegaly. Percussion reveals a normal reverse span of 13 centimeter in the right midclavicular line starting from the 5th ICS with no ascites, that is no shifting dullness.
Okay, everything is normal. Why did you specifically mention no thrill? What does it have to do? Any specific reason? Then you should have said no bruit also. Then you should have said so many other things also. So again, these are irritants. Don't necessarily make things which are not at all related to your case.
Yes, sir.
Carry on.
So, general other system examination reveals respiratory system has bilateral equal vesicular breath sounds, and CNS and CVS are normal on examination. Sphincter tone is also normal on DRE with no bleeding PR or melena, no nodules found on the digital rectal examination. So, in summarizing the case,
What nodules you are trying to feel on DRE? Mucosal nodules?
Not mucosal nodules, sir. We tried to exclude any.
What nodules you were trying to feel?
We were trying to exclude any symptoms of, that means any signs of metastasis on TREs.
Where? Metastasis where?
In the Bloomer shell, sir, in the rectovesical pouch.
Rectovesical pouch. Na? So you should have said that I did not feel any nodules, extra mucosal or extra mural nodules on the anterior, rather than just saying no nodules felt. Go back to your previous slide. CNS, CVS, respiratory system, it says bilaterally equal vesicular breath sound. What specifically were you looking in the chest?
I was looking for, sir, any unilateral or decreased amount of breath sounds in any part of the lung that
Why?
would indicate me if there was any pleural effusion.
Okay.
That would again indicate that it might probably the tumor has infiltrated into the surrounding pleura, or there might be metastatic nodules in the lung that are causing pneumonic or parapneumonic effusion.
So metastatic nodules in the lung will cause any clinical findings?
Generally, no, sir, but if there is gross metastasis, they can cause a pneumonic effusion that would again correlate to a decreased amount of vesicular breath sounds on that same side.
Pulmonary nodules usually don't cause any clinical findings. Pleural effusion, yes, you are right. What else? What else were you expecting? In any patient with dysphagia, why is the chest examination important?
Also, since he has a prior history of smoking, he has smoked for the past 20 years. So we were trying to look out for any evidence of, means if there had been bronchial breath sounds, we would have looked more, we would have investigated the respiratory system more thoroughly.
What do
to
bronchial breath sounds mean?
Means the patient had any bronchiectasis or
Bronchiectasis causes bronchial breath sounds. Bronchial breath sounds are characteristically heard in what?
What is the pathology that is required for bronchial breathing? What basically is happening in the lung?
So there is a small handbook of clinical medicine, Hutchinson. You should all read the chapter on chest. Bronchial breath sounds, if I remember correctly, are characteristically heard in consolidation. When there is a solid lung between the bronchus and the chest wall, bronchiectasis give rise to coarse crepitations. Also in these patients, you are looking for aspiration pneumonitis, so fine crepitations. So in a patient with esophageal disease, in a patient with dysphagia, in a patient with corrosive stricture, in a patient with achalasia cardia, your examination of chest has to be even more detailed than examination of the abdomen, because that is where you anticipate or expect findings. So it is not enough to say chest is normal or bilateral equal vesicular breath sounds. You have to talk of expansion of the chest. You have to talk of percussion note. You have to talk of breath sounds. You have to talk of additional sounds. He's a chronic smoker, so even percussion note, whether there is any evidence of hyperinflation of the chest. Even these patients can have bronchi and crepitations, although they don't have infection. But just because of COPD and emphysema, they can have all these findings. So your examination has to be more detailed rather than just a cursory mention of respiratory system normal. That's very, very important. Important from exam point of view, important from management of the patient point of view also.
yes, sir.
May I interrupt, sir?
Yes, Rajan.
Yeah. You mentioned stenting. What are the locations in the esophagus where you can use stenting and where you cannot use stenting at all? What is the minimum requirement for stenting?
That at least the guide wire or the pediatric scope should pass across the tumor.
Okay.
Number
What did
one.
Dr.
Number two,
Desai ask? He gave you a hint. You have to listen to the question properly. What level, what minimum distance? He didn't ask about whether the lumen is patent or not. That goes without saying. If you can't pass a guide wire, obviously you can't place a stent. So you must listen to the question properly, give a pause of few seconds and then answer. So he asked specifically, is there a minimum level? Is there a minimum distance which is required? Think again.
so, stenting is not usually done in cervical esophagus. So 15 to 20 centimeters from upper incisors, we usually avoid stenting. Also, if it's
In J-junction tumors, if you stent, what problems could arise?
G-junction tumors, also we generally avoid stenting, sir,
Why?
because
You didn't
uh,
listen to the question properly. He asked you if you place a stent at G junction, what problems do you anticipate? And your answer was, we don't place a stent. That is not what he asked. He asked if a stent has been placed for whatever reason, what problems will happen? What will happen? If you place a stent across the G junction, what will happen?
the stent might not anchor properly. It will lead to more instances of migration of the stent.
Is that
Yeah, that's one point. And what
The
about
other is
reflux? What
we will,
happens to reflux?
yes, sir. The other is there will be continuous reflux of the stomach contents.
Yeah, so patient will be very uncomfortable. There's a chance of migration, and it usually migrates into the stomach. Then you have to do a surgery to remove the stent. All this will delay his definitive treatment. So when you're an MCH student, you need to exactly describe what is possible in the particular patient that has been given to you, and then the surgeon examiner will try to elicit from you what are the other things about that stent. You should not agree with everything that the examiner says, because he may try to mislead you to see how thorough your knowledge is.
Yes, sir.
Okay, so this patient has come to you. What will you do? We are already only 5 minutes. What will be your plan of management?
Since he has been investigated previously, sir, we will review the previous investigation reports.
What do you
As well,
expect based on the history so far? What do you expect to see in the reports?
I expect to see growth of the esophagus, that I have to determine its location and its other characteristics from the endoscopy report. Also, since he has undergone FDG PET, I also need to see the uh, his metastatic workup, that is means spread of the tumor, the local spread.
PET is done for local spread.
I means metastatic spread, as he has undergone an FDG PET CT, sir. Only an FDG PET CT, has not undergone a CT separately. So that will give me the.
So let's quickly have a look at the post chemotherapy PET CT.
Yes, sir. This is a PET CT report post chemotherapy, sir. I don't have the images with me.
Just read the
So,
summary so that we can discuss the plan of management.
FDG in a case of CAG junction and adjacent stomach post chemotherapy status as compared to previous CT on 6th July 22. It shows an FDG avid, well defined asymmetrical. 1 second, sir. Well defined concentric wall thickening involving the G junction and adjacent stomach along the lesser curvature, with partial regression in size, extent, and metabolic activity. Complete metabolic resolution of previously mentioned pelvic lymph nodes in the current study, and mild prostatomegaly with focal FDG avidity without any enhancing lesion.
Let's, for the time being, ignore that pelvic lymph node. Let's first just concentrate on the stomach. So based on this report, what will be your broad plan of management of this patient?
For this, I would need to do a repeat upper G endoscopy, sir, to
Why?
locate the epicenter of the tumor, to know the upper extent of the tumor and its lower extent, its exact extent of involvement of the stomach, and to locate the epicenter of the tumor. So that
Why
it
is
may,
that important?
because that would make classification of the, since it's an EGJ tumor, it will allow me to classify it as CWAT 1, 2, and 3. CWAT 1 and 2 would be classified and managed as per esophageal cancer staging protocol, and CWAT 3 would be managed as per stomach cancers. So I would require that information, sir.
Let's go back to the endoscopy.
This is pre-chemotherapy endoscopy, sir. Post-chemo, he has not undergone an endoscopy.
So does it help?
No, sir. It only gives me an rough idea that growth is in the lower esophagus with an also proliferative morphology. Does not give me the distance from the incisors. Neither it is mentioned that the scope could be passed beyond the growth, and I need to look in.
Okay, let's presume that it is a type 3 esophagogastric junction tumor. What will be your plan of management?
Sir, I would be doing a partial esophagus resection along with complete gastrectomy within. I
Is
will
there a
use
term
approach
called complete gastrectomy?
total gastrectomy, sir. Total D2 gastrectomy.
So how
with
much of the esophagus?
Up to the subcarinal level, sir.
How is the lymphadenectomy different from carcinoma stomach for G junction tumors? And what is special about the anatomy of the G junction?
Sir, I would have to remove the lymph node stations from 15 to 20 along with the subcarinal lymph node for this kind of a tumor, sir.
Yeah. So you'll remove 104, 105, and you'll remove 1 and 2, 3 and 4 in the gastric carcinoma. And also you will clear the entire area between the left side of the aorta and the renal vein. This excessive resection is required because there is a retroperitoneal component of the esophagus in G junction tumors, and this results in retroperitoneal spread rather than just a lymph nodal embolic involvement. So that's why this is required.
So Pranay, I think since we are already at 10, I would suggest that you prepare the principles of management of G junction tumors. Okay, classification and principles of management, including neoadjuvant treatment and the surgical procedures. And then maybe we can have a detailed discussion on that. I will request one of the experts on EG junction tumor also to be present. So you prepare a short presentation, just few slides, principles of management, inform Dr. Anand, and then we will arrange another session on this. Okay?
Okay, sir.
Yeah. Any other questions from any students? Any other faculty member? Okay.
No, sir.
Yeah. In the meantime, students, again, send me a mail. Just write esophagus. So I'll send you the chapter on esophagus, the operative surgery details, but then we will have another session on the principles of management. Okay. Thank you, Pranay. Thank you very much.
Thank you, sir.